So good evening. My name is Mike Rinaldi, and we're going to be discussing in this ViewMedi webinar practical use of SENTINEL Cerebral Protection System and insights from the PROTECTED TAVR study. And as I said, I'm Mike Rinaldi. I'm a Director of Structural Program at Sanger Heart and Vascular Institute as part of Atrium Healthcare in Charlotte, North Carolina. And my co-moderator of this discussion is Vinod Thourani, and I'll let you introduce yourself.
Great. Thanks, Michael. I'm the Bernie Marcus Chief of Cardiovascular Surgery at Piedmont Healthcare and also at the Marcus Heart Valve Center and Piedmont Heart Institute in Atlanta, Georgia.
And my good friend and excellent colleague. So here's our agenda. We're going to talk about the prevalence of stroke in TAVR, which remains an issue. We're going to talk about the role of cerebral embolic protection in TAVR. And then we're going to move on to sort of what's next in embolic protection and when to use it in some real world cases. And for that, I'm going to turn over now to Dr. Thourani, and he's going to discuss the prevalence of stroke in TAVR.
Great. Thanks so much, Mike. And also, Mike will be advancing the slides as we go through this. So, Mike, should we go to the next slide?
Yep.
Great. As you can see, the TAVR volume has really increased dramatically, such that over, actually in 2021, we'll be doing over 85,000 TAVRs in the United States. So it's been an unbelievable expansion that I haven't witnessed in my 17 years of practice. This has been unbelievable. It's been based on randomized trials, Michael, that have really driven this change in the management of aortic stenosis. And if you look at it through this slide on through 2019, but also in 2021, really low-risk patients now are roughly a third of all patients getting TAVR, if you look at the most recent data. And so it really has exploded, not at first in the extreme and high risk patients, but now into the low risk patients, such that about 28 to 30%, even at 2021, of low risk patients are TAVR. So, Michael, has this surprised you, this level of increase in a technology over a decade?
So, 10 years ago, we had no idea where this was going to go. But I think with the power of randomized trials and clinical practice, we know that TAVR is effective and it works for patients. And I think it's, complementary to surgery. There's still a major role for cardiac surgery, and we still do a lot of cardiac surgery. But we've touched so many more patients that weren't, necessarily being able to get surgery. And now we have low risk patients, and there's low risk and there's low risk. And I think it fits into an armamentarium. Patients are getting the care they need, and it's being done in a team-based approach with surgeons and cardiologists working closely together. I mean, it's the best of both worlds.
Yeah, very thoughtful consideration. And as we look at the next slide, we'll see that over the years, the rate of stroke at 30 days in contemporary TAVR studies has stayed somewhat similar, somewhere between 2 to 4%. And so you can see that on the left side of the screen, the low-risk patients, the PARTNER 3 had the lowest stroke rate, and the low risk was a little bit higher than that, but still on a relatively 2 to 4% rate across the board. In the intermediate risk patients, you can see it's been hovering somewhere between 2 to 4%. We have seen more in the high-risk patients, but remember, in the high-risk patients, we were also quite new in our technology, and so we were using larger sheaths. We were doing more pre-ballooning. And so, I think overall, I'm comfortable with saying that the 2 to 4% rate of stroke at 30 days in most contemporary TAVR studies. So the stroke rates over time, as you can see, this is a paper that was published in JAMA in 2019, again, stays about the same, somewhere around 2 to, that you can see in the top, any stroke of about 2 to 2.5%. And then ischemic stroke somewhere between that 2 and 2.25%. So overall, we're seeing somewhat similar data between the randomized trials, except for one, and what we're seeing in the real world experience from TVT database. So a lot of the strokes occur not at a month or 2 months or 3 months, they're occurring very early. And Michael, this is very daunting as far as management of these patients, because we commonly tell the patients they're going to go home very soon. That is somewhat of a very easy procedure on you physically compared to sternotomy or thoracotomy. However, what we're noticing that the majority of strokes are occurring within the first day after TAVR, really device related. and almost 2/3 of them are being done within or appreciated within the first 3 days. So when I look at data like this, it makes me really think, boy, this is a area that we can start to work on preventing some of the embolic stroke that occurs during TAVR. What are your thoughts on that, Michael?
Yeah, and I think a lot of the, most of the stroke that's happening is procedural. And even if it's, if it says it happened on day one, sometimes that's just it wasn't recognized until day one.
That's right.
And nobody's going to miss a hemiparetic aphasic patient, but there's a spectrum of stroke, and even minor stroke has been shown to be, really it can affect patients. Like, well, a good example is if a patient has some vision problems and they can no longer read, that's not a major stroke, but it's a major stroke to the patient. So they might not get picked up until the patient's 1 or 2 days out from the procedure.
I think it's also important, Michael, as we do more low risk patients, and they're now, somewhere around 28-30% out of 87,000 that are low risk getting TAVR. I think this becomes even more important because we're expecting their life expectancy, not just 1 or 2 or 3 years, but 20 years. I think that becomes really important. And I think to me, the biggest thing that is worth attacking are the disabling strokes. That's really the ones that I think are the disabling strokes are the major impediment towards getting back to a healthy lifestyle.
Okay. And I think time and time again, these stroke rates of 2 to 4% they're real, especially when they're adjudicated by a neurologist. And you can say, well, I don't see stroke in my practice, but I would say that, not all strokes are obvious. Not all strokes are picked up in the first 24 hours, but consistently, these are the numbers that everybody has.
Yep, agreed. And so assessing, when you look at this is a paper that we had published through TBT Registry, and you can see that the stroke is an independent of experience in operator volume. There are some things like mortality and vascular injuries that do have a strong relationship with operator volume, but you can see that stroke is much less in that category. So I think it's important to note that this occurs to all of us, and without some type of protective device, we have a very hard time protecting the brain from TAVR. So this kind of looks at the TAVR outcomes based on the TAVR team experience. And you can see low volume centers, you can see the stroke rate is about 1.5, and high volume is about 1.3, and the medium volume are 2.0. So that really shows that even high volume centers, that stroke rate is still there, and comparing a low volume and high volume isn't that different, quite honestly, that 1.3 to 1.5. Sometimes things are statistically significant, but quite honestly, they're clinically insignificant. And that's one of the scenarios here. So it's hard for us to predict even a high volume center like ours, where we're doing over 550 TAVRs a year. It's very difficult to tell us when we're going to have a TAVR related neurologic event.
Yeah, you
can't. I would
can't.
imagine the same for you.
Yeah, you just can't experience and practice this problem away. It's a problem for everyone.
Right. So, Mike, I'll turn it back over to you now.
Okay, so let's talk about the role of cerebral embolic protection in TAVR, given that we all recognize that stroke is not gone and will remain an issue for all TAVR. So there is an entire litany of devices that have been developed for trying to prevent stroke in TAVR, because we'll all agree that the best treatment for stroke is prevention of the event. But most of these are all investigational devices. There's one device that has CE mark outside the US, but there's only one device that's actually FDA approved and commercially available in the United States, and that's the SENTINEL device. And there's a variety of interest, though, in the field, as evidenced by a lot of startup companies trying their best to get into the field. So the one device that has the most experience in humans is the SENTINEL Cerebral Embolic Protection Device. It's the only FDA cleared and approved cerebral embolic protection device in the US market. It has 2 independent filters that they don't just deflect, but they capture the embolic material. It consists of 2 polyurethane baskets with 140 micron pores. It's performed from a right radial axis with a standard 6 French sheath. It accommodates most vessel sizes, and it has minimal profile in the arch, so that when you're trying to deliver your TAVR gear, you don't have a lot of interaction with the technology. And the Sentinel device opens and protects the right brachicephalic and left carotid artery, and this covers 90% of blood flow to the brain, except for the left vertebral artery. So a variety, a majority of the cerebral circulation is protected with this technology. So what data do we have to support any use of this of cerebral embolic protection, specifically Sentinel? Well, there's a whole bunch of clinical trials at this point. Many are registries, but there are now some randomized trials and also human experience in the TVT registry. So everywhere from first in man now to large randomized trials. And one of the most important trials early on before the most recent randomized trial was the IDE trial. And this was underpowered, but it was in a different era when strokes were a lot higher in TAVR. And first is the device safe? Can you use it safely without hurting people? And the answer is definitively yes. Even early experience with the technology showed that MACE rates were quite low and below performance goals. And it seemed to reduce new embolic lesions. Now, it wasn't statistically significantly different, but there was a trend towards lower embolic hits in the brain. So there's a physiologic mechanism that might support a lower stroke story. So did it reduce
remember,
stroke?
Michael, also, this was a very small study.
Yeah, very small and underpowered.
When you look at that, there's almost a 63% reduction, but it was very small. I wish we would have done this study with MRI and doubled the number of patients. I think that we would have seen a consistent decrease in volume lesion ratio, and that would have been more pronounced and more convincing in some regards.
That's right. So you're always going to have more power to find different events based on the baseline event rate. And this was a neurologist adjudicated trial where in the group that was protected at 30 days, there was no significant difference because it was weighed out by sort of noise. But the peri-procedural time period, which was not the primary endpoint, but an important analysis of the data. So within 72 hours of the procedure, so peri-procedural, there was a statistically significant 63% reduction in stroke. Now, you might say, we don't say 8% stroke rates in the control arm, but remember, this was a different period of time. And it was also neurologist adjudicated, where they're going to find a lot more strokes. So higher stroke rate at that time, and also neurologist adjudicated. And so there was actually a statistically significant reduction in strokes that goes along with what we see on MRI hits.
So we also see that, Michael, in surgical trials where most surgeons will say, well, I don't have a stroke. There's a great Penn study that showed that there was actually a really high rate of MRI positive and clinically positive. When a neurologist sees the patient, you almost increase the number of events, neuro events, by almost 10, 12 fold if a neurologist actually sees every patient post-op.
Right. And so in addition to the IDE trial, there's now some clinical evidence from registry data from Cedars-Sinai, Ulm, outside of the US, even my own center, have shown in single centers a fairly consistent message of a reduction in stroke rate that was often statistically significantly different. And then there are some registry data in real world use. Now, the problem with registry data in real world use is that this is, potentially subject to case selection. So first, they're not neurologist adjudicated. People are always going to underreport their stroke rates. And also, people may be more likely to use the technology in patients where they think the patient's going to have a higher stroke rate. So that's going to always make analysis of sort of real world registries in the global reported TVT setting a little more difficult to interpret. But we have a fairly consistent message that in real world work that there is some reduction in stroke with the use of embolic protection. So in addition to sort of reduced stroke rates, is there a physiologic story that goes behind this? And I think the answer is yes. Virtually in every embolic, in every basket, if you look under a microscope, you're going to find debris, and that's small debris, yes, but even large particles. The kind of debris that's collected is all kinds of stuff. It's calcium, it's thrombus, it's valve tissue, it's arterial wall, it's even myocardium. And also interestingly from this study, which was the Sentinel low risk registry, is this is stuff that we're finding in patients who are deemed low surgical risk. So it doesn't matter whether they're elderly and sick, or whether they're your standard TAVR or surgical patient. If you put a basket up and do your TAVR procedure, you're going to find significant material captured that didn't go to the brain. And if you look at that material, it's significant. So there's a whole bunch of material that's relatively small, although I don't want that small material to go to my brain either. But in 17%, it's up to a millimeter in diameter. In 4%, it's between 1 and 2 millimeters in diameter. And for 1%, it's 2 millimeter particles. Those are particles that were captured that didn't go to the brain. And it didn't matter what valve you used, whether it's Sapien or Evolut. This is a pretty scary and compelling thing. And when you use the technology, you'll find stuff that's visible in a basket. It's going to be hard to see stuff in the 150 micron range, but if you capture something that's 1 millimeter in diameter, that's visual. And it's very compelling. So let's move on now to the recent PROTECTED TAVR trial, which was a randomized trial that was supposed to give us some more definitive information. And so this was a contemporary trial. So it was recently conducted on, standard technique, standard technology. This should apply to what we're doing today. So 1,500 patients received protection, and 1,500 patients did not receive protection, with the primary endpoint all stroke at 72 hours or 3 days. And this was neurologist adjudicated, so that we're going to detect things hopefully if they happen. And what did we find? So we found that there was not a statistically significant reduction in all stroke. And that was primarily because there was not really a difference in non-disabling stroke. But if you actually look at the disabling strokes, the major strokes, the ones that people don't want to have strokes, but the ones that people really care about, there actually was a statistically significant reduction in stroke from 1.3% down to 0.5%. So a 0.8% delta in major stroke. And that's a big deal, I think. I think it's important and a compelling message. So that's statistically significant.
Yeah, I don't disagree with you at all. Of course, nobody wants any of the stroke on the left-hand side. But if of the two, disabling stroke are really the ones that alter, in my opinion, Michael, they alter your lifestyle down the road. And I think that's really what, we give them a valve. They feel much better from a symptomatic shortness of breath and chest pain point of view, or syncope, but we've really given them a major detriment, i.e. a disabling stroke. So to me, this is the most important of the two type of strokes that we want to minimize as much as we can.
So additionally, was the technology safe? So we reduced major strokes. Was it safe? It was safe. There was no real difference in MACE events. There's no difference in mortality, no difference in major bleeding from the access point, no acute kidney injury differences. So it was, effective for major stroke, and it was safe. And there was no subgroup that benefited the most. The plot is all over the place, but really nothing to the left or right of the plot for all stroke. And so I think it's going to be very difficult for us to perfectly pick, who is going to benefit from this technology the most. It's somewhat unpredictable. We're going to talk about that when we go through the cases, but there's no clear signal that there was no perfect patient who benefits more than others. So in conclusion, use of Sentinel cerebral embolic protection was feasible in an overwhelming majority of patients. So it's deliverable, it works, it gets where it needs to go in 95% of patients where it was attempted. And I felt that in my own practice. Use of cerebral embolic protection did not reduce overall stroke, but was associated with fewer major disabling strokes in a number that I think is probably, in my opinion, clinically relevant. So, you could be statistically different and be only 0.1% different, but nearly a 1% drop in major stroke to me is important. And there were no specific anatomic factors that identified strongly where to segment, is there a population that's going to benefit the most. So lastly, the story is not yet over. So in Great Britain, they're also doing a trial, because in Great Britain it is not yet approved and commercially available. So they you're not going to be able to cherry pick patients. So this is going to add to our body of data and maybe sort of the mother of all trials. 3,865 patients protected versus 3,865 patients unprotected. So this is going to give us even more power to detect differences. And again, it'll be very similar to the PROTECTED TAVR trial with a 72-hour stroke endpoint. So I look forward to finding out the results of this trial. They've already enrolled over 3,000 patients, and so I think we're going to get some more data soon. But in the interim, I guess we need to talk about what's next in cerebral embolic protection, and I guess that's a good springboard back to you.
Yeah, Mike, one thing I'll just mention that, roughly if we're doing in just the US, if we're doing 87,000, just on the last two slides you presented, if we're going to do 87,000 TAVRs this year in the United States alone, which is what we did in 2021, if we go to that 1.3% disabling stroke rate, that's 1,130 strokes, disabling strokes in the US. If we go to 0.5, that's 435 strokes. So there's 700 less patients who had a stroke if you look at those numbers and just extrapolate that out to 87,000 patients. And 700 patients benefiting, not having disabling stroke, to me is very impactful personally. Yeah. So I just want to mention that as I was doing some quick math while you were presenting those two slides. So I think the next topic for me is what's next in cerebral embolic protection. And you can go to the next slide. And you can see that, of course, we've talked about this, that what are the mortality rates in patients who do have a stroke is 4 to 5-fold increase in mortality for TAVR-related strokes. So you're really looking at something on a meta-analysis that was done that showed a 4x and a center collaboration, a meta-analysis of almost 11,000 TAVR patients. You can see a 5-fold increase, and this is 30-day mortality. So stroke is not only bad for your quality of life, but it actually increases your mortality at 30 days. And when you look at this is one of the studies. This is 136,000 patients, of which 189 or 1.8% had the CEP, and 1.94% did not after they were matched. And you can see, again, this is the primary endpoints in hospital mortality and then 30-day readmission and discharge disposition. You can see that on the next slide, that there was again, in-hospital mortality was almost double there, from 6.3% in those that had a CEP to 11.8% who had a stroke without CEP. So it's really becomes very important. Readmission rates are the same, but you can see that those routine discharges to home were much less in those that didn't. But at the end of the day, post-TAVR stroke and other neurologic events, and you mentioned this earlier, are not acutely apparent. And by the time you and I as surgeon and cardiologist see the patient, they've had a major hemiplegia. There are a lot of other silent cerebral infarcts, which are unbelievably important. And I think that this is truly just the tip of the iceberg when you and I see that a patient has a major stroke.
One thing I think that comes along and helps tell the same story is if you look at patients with atrial fibrillation, the ones who have intracranial hits on MRI, those ones, in patients who are treated with anticoagulation therapy or not, those patients have a higher risk in the long run of developing cognitive problems and dementia. So, I think it's not just theoretical. There's data that shows that patients who've had silent strokes in the long run have cognitive issues. So I think there's a compelling reason to try to prevent that beyond just the major strokes.
Absolutely. So here, this is the rate of silent brain infarcts in TAVR compared to other cardiac procedures. You can see with TAVR, it's 4.58. So a really important aspect that we're looking at. And, this just gives you a framework from against PCI or and potential for CABG or an open AVR. So really, this becomes important across the road for TAVI from a paper that was published in 2019. So minor stroke, what we were just talking about, is also associated with cognitive impairment, depression, and physical impairment at 3 years following stroke. This is a very nice study that was done in 2018. And you can see that these patients have not only 44% of them had cognitive impairment, 39% had moderate depression, 34 had severe depression. And of course, you can see the disability that occurs with this. So even minor strokes can lead to not just mortality where you don't have that issue, but you have a lot of other quality of life metrics that we measure that take someone out of the normal working work-life balance that's so important to all of us.
And for me, this is not going to show up in a 72-hour endpoint randomized trial.
Right.
So this is this is a story. This is important.
Right. So they also have an effect that just ties into this for the societal effect, especially as I mentioned to you that almost 30% of patients who are getting TAVI now are considered low risk. They're younger, they're working population. And you can see that a stroke really decreases their social activities. Half of them have an inability to return to work and being productive. And then, of course, significant financial strains that occurs because of these two activities. So the short-term clinical costs of TAVR-related stroke are really high. There's a 23% increase in the cost of the index hospitalization. There's a 4-day increase in of the hospital length of stay, and there's a 3 to 4x increase in hospital mortality. But also increases long-term costs of 30-day at 31% higher readmission rate at 1 year. There's a increase in cumulative 1-year cost by 70%, and overall, the life of the ischemic stroke is estimated to be about 140,000. Quite honestly, when you take into the idea that they can't get back to work, it's probably much more than that. And so I think that that's just medical bills probably, but the loss of productive person in society becomes in some ways immeasurable. So there are acute 1-year and long-term costs associated with having a stroke. And that, of course, is from a very interesting study, in my opinion, in 2015 of what can really happen to someone who has a stroke. It's not only acute, but becomes a long-term problem for them. So really a disabling stroke remains to us in surgery and also in transcatheter valve therapies, the most devastating complication after cardiovascular procedure outside of death. Following TAVR, strokes can really lead to 4 to 5 increase in short-term mortality. CP, it can provide, as you've shown in your beautiful data, 60% relative risk reduction in disabling stroke at 72 hours. And quite honestly, this represents the largest reduction of clinical disabling stroke to date for TAVR procedures. And of course, future studies that you mentioned in your last slide for the last session, that their future studies are confirming this analysis are currently underway.
So now I think we can turn to some real world cases to generate some discussion, and we can talk and sort of tell a story and see how we would manage these patients. Because we both have, do a lot of TAVR and this comes up every day. So let me start with a case. And so this case is what helped me get into the whole field of cerebral embolic protection. So I was not in the IDE trial, and it was approved, and it had just been approved, and it was still a small startup company. And somebody came to me and talked to me about this, and this case had just happened to us, and so it was acute in my mind, and because this case happened to us, I sort of said, this is something I want to own and do and learn and get involved in our program. So specifically, this was a 74-year-old patient who had early ALS, but he was quite functional. He had severe aortic stenosis, class 3 symptoms, and it was a pretty straightforward TAVR. He got a 26-millimeter S3 valve from a right transfemoral approach under conscious sedation for our standard procedures. And he went up to our holding area, and as he sort of recovered from the anesthesia, we found that he was acutely rightly hemiparetic and aphasic, like big stroke. And on scan, you can actually see this big hunk of calcium in his MCA. That's a catastrophe. And if you look at his brain scan, it was like the entire MCA territory. And this was a kind of stroke that you're really not going to survive. It was like practically half his hemisphere. And so we took him to the neuro suite, and you can see it had migrated a little bit, but it was still a major cutoff. And despite, it being during daytime and having all the right people in place, he got TPA, he got a suction stent retriever, he got a suction embolectomy, he got a wingspan stent restoring flow, and it took about 2 hours to get that accomplished because it was not easy to get this giant hunk of calcium out of the way. But unfortunately, he remained hemiparetic and densely, aphasic and densely hemiparetic, and he died of sepsis in rehab 2 weeks later. So it was a catastrophe. I remember it like it was yesterday. Talking to the family, it was miserable. So we adopted it in our program, pretty early, not just based on that case, but it sort of fit. It was a compelling message to our entire team. So is there another way? This is, I think, a fairly typical case that I pulled out of cases that we've done. 87-year-old with severe aortic stenosis, some degree of a depressed ejection fraction, so a higher risk patient, some atrial fibrillation, some chronic kidney disease, calcium score, very calcified valve. This is kind of a typical patient we do in TAVR. These are the kind of patients we do. And so here's our embolic protection device going in. It's really this quick and easy. And we've got the vessels protected at this point. And
I'll ask you, what percentage of your patients have a weird enough anatomy that you're unable to do it? In 5-10%?
Yeah, I think that's about right. So, things that would keep us from doing it are, if I can't get radial access, I haven't typically gone brachial, or if it's really, really difficult anatomy. And we screen them with CT, we're screening everything. We're screening their vascular access. So we sort of have figured it out. And I'm not going to flog away at an arch, but fortunately the technology works in, most cases, and it doesn't really add much time to the procedure. And in fact, this is a good springboard. So we looked at our own experience, and we presented this in abstract form. Someday I'm going to publish it, but we presented this in abstract form at ACC and TCT. So of 376 consecutive cases in our lab of 200, there was a learning curve on this, and so not every patient got protected early on. But we showed, a substantial reduction in stroke. Now you can say maybe you just cherry pick the cases, but honestly, the things that motivated whether we did it or not, whether they had radial access and whether we thought that we could deliver the technology easily. And again, we weren't super aggressive at first, and there really weren't. And when we looked at the demographics between the two patient populations, there wasn't a difference. Now, this is sort of simulating a randomized trial. It's not a randomized trial, but this is what we found. It also, importantly, did not increase complications, and it did not increase procedure time. So wheels down to wheels up for TAVR procedures. We were doing up to 5 TAVRs a day at this point, and it really didn't add any time because you can do these procedures sequentially, right? Concurrently. You don't have to do one then the other. While somebody's getting radial access, somebody else is doing something else, and it works. It flows. It's not hard to do. So here's the real case. That was the story behind our program. Here's a more complex case to generate discussion. 77-year-old with severe aortic stenosis, an EF of 40%, class 3 symptoms, AFib with a remote stroke, now treated with apixaban, prior CABG with patent grafts, diabetes with chronic kidney disease stage 3, and a BMI of 40. So they're a standard patient. And what's interesting here is if you look at this echocardiogram on the LV outflow tract view, you can see a mobile mass on the aortic valve on the non-coronary cusp. And the patient had no history of endocarditis, blood cultures are negative, no fever, no nothing. This is probably a mobile component to atheroma or calcified plaque on the valve. The patient was, refused surgery at the outside hospital, and he didn't want surgery. And our surgeons were not super eager to do a redo on a 77-year-old with previous stroke. So how would you manage this? Looking at this case, it's not wrong to do surgery here, but with this background.
Yeah, look, I think that this patient, represents a higher risk patient that surgeons across the country, I think, are not operating on because we have so many different options. And for me, it becomes somewhat of a no-brainer that this patient, gets TAVR. But, in the past, we would have just done this and kept, crossed our fingers and maybe not done a BAV, not to do things to kind of just do one inflation and hopefully be done and pray that they didn't have a stroke. But there's no doubt about it. For us, we would use near protection with CEP for this, and then do a TAVR valve on this patient, and that'll give them at 77, hopefully it will last for 10 years and last the rest of their life.
Yeah, and I think there are scenarios where you might sort of say, gee, we'll try we'll do surgery here, but I think this is not the greatest surgical candidate in the world, but and there's a continuum. But we felt like while it was still risky, this is a case that had to be done with embolic protection. And this isn't our typical case. You don't see this case very often.
Right.
But and this is not the only place to use cerebral embolic protection, but I think this is a very compelling case for the use of it, where it may change the decision between whether you do a high risk surgery or you just do a TAVR with protection. Right. So I'll show sort of what happened. It was a pretty straightforward case. We put our embolic protection device. You can see the still image on the left, with pretty straightforward. We placed a SAPIEN 3 valve, and actually the patient had a small event. They had some mild diplopia. We were unable to do an MRI because the patient had a non-conditional permanent pacemaker. The CT was negative, but the event resolved in 30 days. And I guess I'm showing this case because it's real world, and I think this is a win, because with that mobile goober on the aortic valve, this could have been a massive stroke. And it's possible that putting a device in like this averted a major stroke. And maybe this explains some of the difference in the fact that that there was not a reduction in minor stroke, because this
wouldn't have been in a trial, right? Because you don't put these patients in trials, but this is real world experience, Michael. And I think that this is what makes it important. And there are some programs who don't use CP, and I think that this is the type of patient that they would have a major chances are greater than 80% that they're going to have a major complication from this. So absolutely the right thing to do. And I'll take diplopia anytime, over hemiparesis. That's the way I look at it.
All right, and you have a case.
Yeah, I do. This is a patient. And the reason I wanted to throw a bicuspid valve patient, because this is kind of where we started with doing it, these really heavy calcified valves, where we started using more and more Sentinel. Obviously, I was in both the trials, but this is a patient who is a bicuspid patient, but a little bit riskier bicuspid patient. 7-year-old, uses a walker, creatinine is 1.5, and you can see a big smoker, and has severe COPD. And so, although this is a bicuspid valve patient, and where we started using a lot of CEP because the calcified valves are so bad, I think this is just an example where I think hopefully we got pretty lucky here. So I'll show this case next. Next, you can see the coronaries are clean. These are still pictures, but the coronaries are clean, so nothing really spectacular to do with that. You can see here the echocardiogram shows a pretty good ventricle, but it's a little bit depressed. Next slide, you can see the valve really is a nasty looking bicuspid valve. Wow. If this patient wasn't in a walker, didn't have creatinine 1.5, didn't have severe COPD, I think absolutely this patient didn't have 3 strikes against them. I kind of look at how many strikes somebody has against them, and this person had 3 strikes against them. This patient, I think, would have gotten the knife and the blade and would be opened up, and I would have cut all of this out. And the valve area is 0.7 in this patient, but you can see pretty gnarly valve, wouldn't you say, Michael?
That's brutal amount of calcium. That is scary.
Yeah. So the next, you can see here large amounts of calcium across the board for this patient. This is a CT that just again represents the amount of calcium on both the annulus and the leaflets themselves.
And that's a really frightening looking valve, because that annulus is a little bit hostile.
Yeah, I was
PVL and a perforation.
Yeah, no, this is one of those that is not for the meek. And if you look at the next slide, you'll see that this is pretty heavy into the LVOT. I wish this patient had good lung function or didn't use a walker, and we would have been able to operate on this patient. But you can see the amount of calcium we were dealing with. Next slide. This just gives you another look at the valve itself. The coronary heights are good. You can see 18. Just shy of 19 for both the left and the right side. So that's one good thing that we had going for the patient, is that the coronaries were a little bit on the higher side, and he didn't have a massive aneurysm. You can see they were 40 by 36 by 34. So not huge aortopathy, just a pure nasty bicuspid valve.
And this was a Siebert 0?
Yeah.
Yeah. So he doesn't have a super calcified raphe. It's a big bulk, but this is a little more reassuring.
Yeah, this is all in the leaflets. The legs were surprisingly, I have to be honest with you, surprisingly, the legs were really nice.
Got to have something good going for him.
So, yeah, there's 1 or 2 good things going for this patient. And on the next slide, you'll see we decided to go ahead, and this is back in the 2020, 2021 range, and we decided to go ahead and place this because we thought it was so important for this patient. You know, two things that we were worried about for this patient, I have to be honest with you. Number one is a big stroke and a disabling stroke, and number two, root rupture. Those were the two things we were worried about for this patient. And a PVL I was worried about, but not as much as a root rupture and a stroke, because I think PVL, we can get the patient usually with a plug or something else. We can get them through that aspect of it. And on the next slide, you'll see what we were. Look at that. That's a lot. That's a lot. That's just a lot of debris. I don't think you need a microscope, Michael, to tell me that those are particulate matter. You can see the little ones, and those are millimeter ones, but look at the big chunks of calcium. There's no doubt in my mind that one of these would have landed in the brain. Some of them might have gone to the kidney and taken them from a creatinine 1.15 to 5.5, but what I was worried about was the brain, and there's no doubt about it that this has a very high likelihood of something going to the brain. So we were pretty lucky with this. And on the next slide, you'll see.
But and just so I want to throw in there that, you know, if you do these and you actually look at the filters and don't just throw them away, this is not every case, but it is not infrequent that you see visible stuff like this. And that's very compelling to me, because those were in your carotid arteries. They were going north.
Yeah.
That is, you know, pretty compelling.
Yeah. Yeah. And this is an echo for 6 months later. You can see there's really no, maybe trace, maybe a little bit of PVL, but beautiful. Right there at 12 o'clock, but something that I think the patient can easily live with, has been living with. And this is, the case was done in 2020. And then here's an echo from 2021. And you can see the mean gradient was pretty good at 7. So I was happy with that. We didn't have a root rupture. The patient lived for the 6-month echo and it's done well, and mean gradient's under 10, and we were able to catch all that debris from the patient. Did go home the next day. After the TAVR procedure, we use a Sapien 3 for this patient. I think that may be my last slide there. Yep. So you want to go through these, Michael, on the
Sure.
final thoughts?
Sure. So some final thoughts. You know, I think we've demonstrated that stroke remains a significant complication of TAVR. It's not every case, but it's not no cases, and it is bad. The use of cerebral embolic protection offers a method to reduce periprocedural stroke, particularly, you know, severe stroke or devastating stroke. And the Sentinel device has been shown to be effective in capturing procedure-related debris during TAVR while maintaining an appropriate safety profile. It really doesn't add a marker of adverse events. And the PROTECTED TAVR trial has, and the British PROTECT TAVR trial will provide data that with regard to the efficacy of Sentinel in reducing clinically apparent strokes after TAVR in an all-comer population. So, you know, I think we have some data now. We have some data that is, you know, we're not taking strokes from 10% down to 1%. We're taking real world strokes from in the range of 4% down to, you know, 2%, and major strokes from 1.3% down to 0.5%. That to me is important. And we're going to get more information, but we have data now. And I think that for me, it's still a useful technology, an important adjunct to TAVR to try to reduce one of the most important consequences of TAVR that we have.
Yeah, I agree with you, Michael. And just kind of my final thoughts is that, and I know that with the New England paper recently, and I know the overall mortality, the overall stroke rate was not seen to be significant. For me, I think that disabling stroke is what I worry about. And for me, that was significant. And so that has had our program here at Piedmont Heart Institute look a lot closer at the implementation of CEP for the TAVR patients. Where, you know, we do over, 550 or north TAVRs a year. And if we can avert, even 3 or 4 strokes a year, that's a big deal to us. And so that's kind of the way that we've been looking at it. And it's been the recent data and the upcoming data are very impactful for our care in these patients.
Great. And so I really appreciate everybody listening in, and I have no final thoughts, and I appreciate everyone.
Great. Thanks, everybody.